Hi, my name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in my podcast, and I'm so happy you're here. It's the first time I've ever done an intro that was that neutral or quiet and calm. I'm trying out different intros, so I was going to switch it up, keep this fun and fresh. Um, I think I'm three years into this, a little over 3 years into this. I love doing this. It does not get old, and I hope you see that. I hope you get that from the videos. So today I want to discuss testosterone. And I've spoken about it in the past here and there, but I wanted to really drill down into it a little bit more and be very clear with you on it. I know that testosterone is a controversial thing to use in women. And I was just speaking with Evelyn, and she's the producer of the podcast. And I wanted to talk to her about, like just this is why we're doing this, because there's some women who've had testosterone done. It's been an awful experience. And then there are other women who've done it, and it's been life-changing. And then there are women who've done it, and they're like, notice nothing. And, again, it's a huge controversy using testosterone in women. My goal is to shine a little bit of light in here and give some clarity, the best that I can. The way that I like to do that is to share with you, like, why I use it, why it's a good idea, how I would like to be careful with it, how I run the labs, how I make this safe, my justifications around that. I also want to let you know, like, what if the patient does not want to do testosterone? What do I do in those cases? How do I manage their care? And there are ways of doing it. So I want you to know I'm not a testosterone doctor. I'm not a hormone doctor. I'm a person's doctor. I'm a doctor to you, to the individual, the patient that I have in front of me. And so I don't have an agenda like everyone has to be on this or not that. And if these are your symptoms, you must take this. That's not how a physician works or should work. It's more along the lines of you come in, this is what you're experiencing. There's something not right in your health. It's my job to navigate that with you and share with you the ways different therapies could work. And then your job is to make the decision on what therapies you want to use. And then my job now is to make sure that that does work and that there's no gaps in your care. So there's always exceptions to all these things too. There's like, so someone has type 1 diabetes, you really must take insulin. There's no arguing that. But like testosterone, is there a chance that you could do something different? Yeah, we'll go over it. What are the risks of not doing testosterone? And then how do I avoid those risks? We're going to go over those. So about to start, but as always, before I start, please do me a favor. Roll down a little bit into whatever platform you're on. If you're on YouTube, just scroll down a little bit. You'll see the subscribe link. If you're just listening to this on Spotify or Apple podcasts or anywhere, wherever you get your podcast from, just find the subscribe button and hit it. And if you like the material, please share it. Please press like. And if you think it'll help someone please share it. And let's get into this. So testosterone, I remember when I first saw it in a case with a patient. I was in med school. I was on a rotation. I saw this woman's testosterone was so high relative to the normal. And it was within range, but it was still higher than I expected. And I was like, what is this? And I was like, something's wrong. And I was worried. And this is the first time I ever met a patient who a woman who had had testosterone replacement therapy in the perimenopausal state. And I did not recognize labs like that. I'd never seen them clinically. And it's not something that's in the books. It was never something really taught. Because again, testosterone replacement therapy in women, not really well documented, not really well researched, not really well illuminated in the field of medicine. So it was one of those things that startled me because I had no framework of understanding. And even to this day, when I practice medicine and I treat someone with testosterone, in the back of my mind, I always know there's going to be another doctor who's going to see these labs and not understand. Part of the job when you do hormone replacement therapy with patients is to let them know, there's a chance if you go to another doctor and they see your labs, they're not going to understand this. And it's our jobs to always explain to you why and why what we're doing is healthy. And in a way, my job is also to do my best to make sure you know how to educate your other care providers that this is okay what you're doing, because a lot of the times they're not up on this. They're not keeping up with it. And it can be confusing when you go to another doctor and they say, this is crazy. What is this? What's going on here? And they don't understand. It can be very confusing to you as a patient. Patient education and testosterone replacement therapy is everything. So when I started this, when I first saw this, the woman, it had made such a difference in her perimenopausal state. She was such an advocate for it. It still sits with me. I remember her. She's a very empowered woman. It was the first time I ever encountered this. Fast forward after graduating, I'm in practice in my clinic, and I'm treating a fair amount of estrogen dominance and women with PMS and symptoms along those lines with inadequate levels of progesterone. And I would always have these patients where progesterone just wasn't enough to offset the impact of estrogen on their body. I would get the progesterone up the best I could. It still didn't quite do the job. They would still have some symptoms of estrogen dominance. They still have some breast pain. They still have some anxiety, breakthrough anxiety. They still would have, these symptoms that were always attributed to that estrogen. I had one patient who was dear to me. We call her patient zero lovingly because she was the first person I ever prescribed testosterone to. This was for a long time ago. She had been going to a local clinic. And at that clinic, this is going to be the gist of today's video, by the way. When you're a doctor, it's so important to be aware of your own mental health. It's critical. Feel me for a minute on this. If you go to a doctor who doesn't have really good mental health, those are the doctors you see who have pathology. Those are the ones who have that God complex, the sociopathic physicians, the ones who are not empathic. There's a lot of bad things happen. When you're a care provider, it is so important for you to be as clear as possible. When you have a care provider who's not well, and I'm not stretching by saying that, sometimes they're going to take their own pathology out on the world around them. This patient that I was seeing was going to a local clinic. The physician there was notorious for high dosing testosterone, but everyone wanted to go. There was a lot of hype around it. And this is, 2006. It was almost 20 years ago. He was very popular. And it was a buzz around town, like, this guy will get your libido up. And this guy makes you really, muscles for women. It was mostly treating women with testosterone. But it was really all about libido. And he was doing heroic dosing of testosterone in these women. I'm saying all this because if a doctor comes to clinic and they have an issue around women's libido, they're going to treat women through that lens. If you're going to sit down with a doctor and they don't have a good mental health around physical fitness, they have maybe dysmorphia, they're not going to be good with prescribing testosterone. If you go into a clinic and the doctor is yoked, like just really big, obviously they're abusing steroids. That person is not well around their understanding of testosterone and their own dysmorphia. And this is a truth. It's a quiet truth that no one talks about. I'm going to talk about it. So if you have a man who is prescribing testosterone and they have imbalances around their own libido and their relationship with his sexuality, and they see women through a certain lens, they're going to treat every patient through that lens. I believe this is one of the big problems with prescribing testosterone in clinic with men, is that they treat it, through that lens of either dysmorphia for muscle mass. They feel like everyone should have these big muscles. It's kind of like a body image issue. Or they have this dysfunction around libido. And when you go to these clinics and you're treated, that's when the worst side effects happen. So this patient zero, was going to this clinic, and the dose was pretty extreme, and it was only based upon her performance, and that's the thing. And I've said this before, and it's one of those little things that came to me once in clinic. I was talking to a woman. It's just, you're not performance art. Your libido is a very personal, intimate thing, and you're not performance art. You're a human being. And libido is so misunderstood in medicine because it's not really spoken about really well in medical school and in the literature. There's so much pathology associated with this. Still, I'm going to try and do my best with it. In my mindset, what is libido? Libido is you're born, you are you, you're your own person. And I don't think it's healthy to judge your libido based upon someone else's expectations, ever. Libido is yours. It's a part of you and who you are. Your comfort level with it is our job. That's where I step in to be helpful when it's not right, when there's something out of balance. If it's because someone else has an expectation of you, that's not where the place we step in with testosterone. We shouldn't be using testosterone to solve someone else's expectations. So when a patient presents to clinic, libido is important, but it shouldn't be something where I'm trying to soup them up and cause something super physiological to occur in their body that's not consistent with their own biology and their own identity. When I first saw this patient, she's very, very, very feminine, very, very strong estrogen. One of the first patients I ever had where I was seeing estrogen hitting like 800 during her perimenopause, and using progesterone didn't quite cut it. So she had gone to this other clinic, she had gotten testosterone, and she did not feel right at all. Running lab work, I found, one, it was way super physiological, beyond, reasonable, and downstream metabolites, dihydrotestosterone, were very high. I stepped into that space, wanting to be helpful. So being a doctor, you learn what you learn in medical school, and that's never enough. Never enough. Even when you do residencies, never enough. Even when you get out, never enough. You must always, always continue training. You must always, always, always go back and study more, go do more courses. You spend more time every year. You have to do a lot of these things called CMEs, and you shouldn't just do the bare minimum continuing educational credits or continuing medical education credits. You really should be going more than just the bare minimum. You really should be going after like stuff you're passionate about and really driving yourself. So I remember in those early years, I would go to these conferences, and I would just go to ones for endocrine, for testosterone replacement in women. And, it was eye-opening to me because it was still, a lot of it was viewing it through that titillating lens of like, we're giving women testosterone, they're going to feel crazy and blah, blah, blah. And there was no real good science behind what they were prescribing. And I'm paying money. I'm flying across the country. I'm sitting in a lecture hall, and I'm listening to this guy talk about treating women as objects. If you ever watched my podcast, you know how that would strike me. No matter what, it's like not good. But this is what was out there for a long time. It has gotten much better, much, 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 much better. I'm trying to give you the history of this because there's some of you out there that giving you testosterone will be the most remarkable thing we can do for you. Remarkable thing. Remarkable. It will have such a great impact on your health. And some of you have gone to clinics and have experienced what I'm talking about, that objectification and that inappropriate treatment. And some of you have heard these things and are terrified. My job is to shine a little bit of light into this and help you understand a little bit better. So that way, if you have had trauma with it before, maybe you'll give it another chance. And if you want to go down this road, I want to give you the tools on how to navigate this, how to screen your physician, how to find the right physician who's going to be helpful to you, and how we can make sure it stays safe. That's the goal. And that's the goal of this series I'm about to do. I'm fond of saying this because it's a truth. I have estrogen in my body. I have to. There's no man out there that doesn't, unless they're doing weird stuff with steroids, and they're blocking all their estrogen, and that's not a long-term survivable thing to do. You need it. And so I have estrogen in my body. And just as you should have testosterone in yours. This is the harmony within the human body. When it's missing, there'll be a problem. When it's ignored, there's a problem. When you're treated like a man, there's a problem. When you're treated like an object, there's a problem. But when we do it right, through the lens of you being a woman, through the lens of what is possible when I get you to be optimal, what can be done to help you bridge that window between, perimenopause and menopause. It is such an important therapy. And, in 20 years of practice, I have had so many good successes with it. Challenges as well. I'll go over them with you. So many good successes. And I want to do my best. So as always, if there is something in this series that doesn't make sense, we're going to do this in the next 3 videos, I think, or so. If something doesn't make sense, you have a question, a concern, a worry, like, hey, what is that? Should I do that? What did you mean by that? Anything. Put it in the comment section. I'm getting better about responding to the comments on YouTube. Okay. I'm watching YouTube again, but Instagram tends to be the place where I see the most comments. I seem to be navigating that one a lot easier. But give me a comment. Let me know, because I want to do good work with you. I really want to do a very good job. It's very rewarding to me as a physician when I execute this at a higher level. It helps me become a better doctor. It's my sense of purpose. It fulfills my sense of purpose in life. This would be helpful in this area. So your comments are always welcome. As I mentioned in the first beginning of the podcast here, if you like what I'm doing, hit like. If you think it'll help someone share it. And if you want to keep continuing getting this material, subscribe. All right. I will see you at the next episode.